Hello, and thank you for joining us tonight for our free webinar, Sports Medicine Acupuncture Protocols, an integrated TCM and anatomical view of motor entry points, featuring Matt Callison. My name is Jeff Bloom, Education Marketing Manager here at LASA OMS. For over 40 years, LASA OMS has been striving to promote the growth of the acupuncture industry by providing quality products, great prices, and the best customer service, as well as supporting the many schools and continuing education efforts available. With our free webinar series, we intend to provide free educational opportunities taught by some of our industry's most renowned practitioners and educators. I would like to take a moment to acclimate you to the webinar room. To the right of the video screen, you will see 3 tabs: Chat, Questions, and Polls. To chat with other attendees or to communicate any technical difficulties, please use the Chat tab. For questions of the guest speaker, please use the Questions tab to the right of the chat window to assure that we see them at the end of the lecture. And then please note that each webinar is recorded, and immediately following the conclusion, you will all receive an email with a link to view the video on demand and a copy of the slides. And you may always visit our blog and use the free webinar tag to find all of our previously recorded events. From sports acupuncture to neuroscience to Chinese herbs, you'll find something interesting for every practitioner on the LASA OMS blog. Now for our featured speaker. Matt Callison is a pioneer in motor point acupuncture and has spent over 30 years researching, refining, and treating muscle motor entry points through the lens of Western biomedicine and traditional Chinese medicine. Using surface electrical stimulation, research articles, and documenting the locations of muscle motor entry points through his own cadaver dissections has been a career-long endeavor. Matt Callison is a master in needling and is well known for designing very effective and innovative treatment protocols that include motor entry points with traditional acupuncture points. Matt has taught the use of motor points in TCM treatment protocols for over 30 years in the United States, Canada, and New Zealand. So really quickly, before I hand things off to Matt, I did just want to mention that an educator in the industry named Lillian Bridges just found out that she has a rare form of cancer, and there is a GoFundMe that was just put together to help put together some money for her. So I'm going to put the link in the chat for anybody who would like to share. And now, join me in welcoming Matt Callison.
Jeff, thank you very much for that. I really appreciate that. And Lillian Bridges is really quite the pioneer in our field. My goodness, and what a very special person she is. So she's diagnosed with neuroendocrine cancer, and we just donated to GoFundMe. It looks like there's quite a few people that are donating right now. If you could please help out with this, that would help quite a bit with the costs of what she's going to be enduring with this. So that would be great. Thank you, Jeff, for posting that link. Really appreciate that. So you guys, thank you very much for coming. Really appreciate that. I think these are usually about half hour, maybe 45-minute lectures. This one might go a bit longer. This one might actually go an hour 10 minutes, maybe hour and 15 minutes, and then we can open it up to some question and answer. It's been so long since I've actually discussed my history of investigating motor points that I thought I'd just take some time to be able to do that, and then how it has evolved so much over this last 30 years in treatments and how I'm using them. So let's go ahead and start in the very beginning. So I started in I graduated from San Diego State University in 1986, and I was in physical education, athletic training, sports medicine, kinesiology. Now in the training room, my first exposure to motor points was when we were told to go ahead and put a 2x2 or a 4x4 electrical pad over the central aspect of the muscle, because that's normally where the motor innervation would be, or the motor point would end up being. Now we would put one pad on the motor point. We could put another pad either distal or proximal on the muscle, depending on what we're trying to do. Or we would go ahead and put one motor point on an agonist muscle. We put a pad over the motor point on an agonist muscle, and then we put the other pad on the motor points of the antagonist muscle. And that actually has taught me quite a bit, that particular technique, wondering what it would be like to do that with acupuncture needles, and the Watto arc treatment method was born from that. So we'll chat about that in just a little bit. So that was my first exposure to motor points, is using electrical pads over the central aspect of the muscle. So with a 2x2 pad or a 4x4 pad, I mean, it's fairly easy to get over that innervation site. And as turning an acupuncturist and having a very small myofilament needle, and then now trying to be able to put the acupuncture needle into the motor point region, well, that took a lot more investigation, a heck of a lot more investigation. So that's what I did. I started looking up a number of different articles, going into my own cadaver dissections, looking for motor points, electrocuting a friend of mine for 4 days in a row to be able to find out as many motor points as possible. And he actually did a really good job of that. We'll see him a little bit later in this presentation. And then from there, I would document and then document those motor point locations based on anatomical locations and acupuncture points. This was written for the acupuncturist so that the acupuncturist could use these motor points for an eclectic ashi point or go-to point, because what I was finding is by needling these very specific ashi points, it would change range of motion, it would change manual muscle testing, it would change orthopedic examinations. And we'll talk about that in just a little bit more. So that first work was actually published, let's see here. Was I able to advance this, Jeff? There we go. So that first work was published in the year 2000, the Motor Point Manual. And alongside with that was the Motor Points and Acupuncture Meridians wall chart, which has actually been recently updated this year. So that was actually when it came out in the year 2000. And I was, like I said, we were lecturing quite a bit over the United States and into Canada. I was going to New Zealand quite a bit, and also Australia, talking about motor point acupuncture, really, and how to be able to use motor points in addition to traditional Chinese medicine acupuncture points for the treatment of musculoskeletal pain and Zong Fu disharmony. Now, from there, the Motor Point Index, which is a flip chart, it was a very, very popular book. It's now only available on digital. A lot of people are asking for the return of that, which eventually it will come, but not tomorrow or the next day. So the Motor Point Index was published in 2007. So that was an involvement of motor point locations from the Motor Point Manual. Then in 2010, no, actually, I think it was in 2007, is when I started teaching at Pacific College of Oriental Medicine. Now, I graduated from Pacific College of Oriental Medicine in 1992. So then in 2007 or so is when I actually started teaching there. I created a class called Treatment of Orthopedic Disorders. And then as the campus expanded to Chicago and New York, so did the treatment of orthopedic disorders. So in my writings, this book on the right, it was about a 243-page manual, and it talked a lot about motor points and how to be able to use them and a number of different injuries and the applications of motor points, orthopedic examinations, manual muscle tests. And that was, the first edition was in 2011, and that was used in all 3 campuses. The second edition came to 2013, and it is still being currently used at all 3 campuses. So there's been quite a bit of exposure about the motor points and motor point acupuncture for quite a long time. So then the treatment of orthopedic disorders eventually turned into the Sports Medicine Acupuncture textbook. Now, this was released in 2019. That's about 1,300 pages. It's a very, very heavy book. Lots of information in this book. It has the most updated, I would say, motor point locations. Actually, the most updated motor point locations will be in this book, and even some of the locations in this book have changed a little bit just based on recent anatomical findings. So there's more to talk about that on a different day. The most updated information will be the motor point protocol recordings that we have in the SMAC program, which LASA OMS is carrying. Then I've also updated the motor points and acupuncture meridian chart. That is in 2021. Again, these are going to have pretty much the most updated motor points. There are going to be some variations. Like I said, the most updated will probably be the recordings in the motor point protocols that LASA OMS has. Now, what's amazing about starting to needle motor points is how it would go ahead and change range of motion instantly, how it would change pain, how it would change myofascial tension, orthopedic examinations, manual muscle testing. And this was something that I got very, very excited about. And this is what really helped to drive more and more study about motor points. And it just hasn't really stopped. It's a lifelong challenge to be able to document where these motor points are and actually to see the variations of where motor points are located from human to human, because they're not always fixed. I mean, some actually you'll see will have motor points on one person, and then the next person may not actually have the same motor point, or might be in a slightly different location from a different diameter nerve. It's curious. Now, as far as motor points changing range of motion and manual muscle testing and freeing up pain, this is not something that's new. This is something that's been going on for thousands of years, where a barefoot doctor was using acupuncture to treat somebody else in the village because they couldn't bend over very well and do some farming or something like that. I'm making this up, but this is something that actually most likely happens. And so what they did is they had points of experience. And certain points, maybe channel points, maybe it was a chi cleft, maybe it was a luo point, maybe it was a point of experience, which some doctors currently in China are calling motor points. They would use a certain motor point to be able to make a big change in that myofascial sequence, or that myofascial channel, in order to free up range of motion. So this has been going on for thousands and thousands of years. It's just today that we're discussing it in a different way. All right, so this is a warning that we usually have anytime that we're going to have a lot of cadaver, any kind of cadaver videos or images at all. I'm sure that everybody here that is signed up for this is not going to have any problems with the cadavers. However, for those people that are looking at this recording maybe a year or two from now, and you are luckily in a public area with no mask on and there's lots of people around, but if you're watching this, some people get really freaked out about human anatomy and cadavers. So let's be mindful of that. I mean, people can get really guttural instincts when they see a cadaver image. So let's be very, very mindful of that, please, of your surroundings. Let's make sure there's no screenshots with this. We're not going to share any of the recordings, and no downloading at all. That would be really, really very, very useful for everyone. Thank you for your attention to that. So let's jump right into the motor points. Now, the electrophysiological definition of a muscle motor point is still not universally agreed upon, and finding precise motor point locations has proven to be an ongoing challenge. Absolutely, this is something that I commented on earlier. The number of motor points per muscle vary between subjects, where some individuals have predictable muscle motor point locations, absolutely, while other subjects did not have the same motor point location at all. An example of that would be, it's really common for the tibialis anterior to have two motor points, one located at stomach 36 and the other one located too soon inferior at lan wei shui. Some specimens will only have a motor point or a collateral branch coming off the peroneal nerve going into stomach 36. Another specimen may only have it going to lan wei shui. So it's variable. This was an interesting article that I grabbed this quote from. It was on, the article's about electrical stimulation placement for 2x2 pads, 2x2 inch pads, or 4x4 inch pads, and it's for abdominal motor points. And they got really excited about this, and they said intrasubject repeatability shows motor point positions changed a little at 1.7 centimeters. So the variation was 1.7 centimeters. Well, as we know, if we miss an acupuncture point by 1.7 centimeters, or shoot, even 1 centimeter, are we getting the same quality of stimulation? No. I mean, some points are really very, very small. Some points are bigger, right, where you can actually miss it by a centimeter and still get some quality stimulation. But for most of us, we really need to be able to get at least within a 1/16 of an inch of that point. This is why we take so much time in school to be able to understand where these points are and how to be able to feel the points. And the motor point has been described as the zone of innervation, which in turn can be defined where the motor point first pierces the muscle belly, the motor nerve entry point. This is something that we are calling this, the motor nerve entry point, where the actual motor nerve will go in and insert into the muscle itself. This is usually where you'll have the largest diameter of nerve fibers. Once that nerve then goes in and pierces that muscle, it will then bifurcate, usually go proximal and it'll go distal. Many times the nerve, the farther away that it travels, the smaller and smaller and smaller it gets. We've actually have dissected it out, and it gets so thin that you can't find it anymore, at least with normal eyesight. So when you have the motor entry points, then you have the nerve that's traveling intramuscular, and that would be then called the intramuscular motor points. All right, so what we're looking at now would be an ulnar view of the forearm. I'm holding the ulnar nerve, so that would be the ulnar nerve there. Then you have a collateral branch that's coming directly off of where the thumb is. The collateral branch is going right down into that flexor carpi ulnaris. Then below that, you can see a needle sticking into the flexor carpi ulnaris muscle. So that muscle right there is the flexor carpi ulnaris. So that collateral branch is entering the muscle from the radial side. And this is what I think is so important for acupuncturists, is to understand where is that nerve going into the muscle. That then tells the acupuncturist how deep to go ahead and needle. Now, of course, we can get chi on this flexor carpi ulnaris if we went just past the skin and just touched the fascia profunda, the fascia that's just covering the muscle itself. We could definitely get chi at that level. But would we actually change, let's say, a ulnar nerve entrapment of the flexor carpi ulnaris? Or would we actually change the tension within the small intestine sinew channel if we just tapped on the muscle itself? In my experience, it doesn't work as well. If we go in deeper to where that particular motor entry point innervation is, that's when you actually get a stronger sensation. Now, of course, that stronger sensation can be minimized by a thinner needle. But again, we're just trying to get that electrically conductive metal of an acupuncture needle into this point that is so reactive. And this is where the Chinese, I believe, were using motor points for years and years and years, thousands of years, to be able to create different changes within the sinew channels, within the primary channels, to be able to move qi. And they were masters at how to be able to treat particular points with certain depths. And this is something that I would like to be able to share with you from my 30 years of experience in doing this. This is my friend Nick, and he's still a friend of mine even after electrocuting him for 5 years, for 5 days in a row. So I use a galvanic stimulator that's an 8mm probe. It's over the point gallbladder 14, which is one of the motor points for the frontalis. It's one of the more reactive points for the frontalis, innervated by the facial nerve. It has the largest branch going into the frontalis. So the skin above the motor point on superficial muscles also has a certain constituent within that subcutaneous tissue that helps to transmit the electricity. Now, for example, if I go ahead and on this image, you can see with electricity output, you can see his eyebrows raised up a little bit. So that's stimulating the frontalis muscle. You can see that it's raised up. If I went ahead and moved the electric stimulation just over, let's say, I don't know, 0.5 centimeter, with the same electrical output being really quite minimal, it would not contract. If I go back, it would contract. Then, this is the tricky part about it. If I would then move the skin and put the electric stem exactly at gallbladder 14 and use the output, the muscle would not twitch. There's something within the skin itself that's part of the electrical conduction for the motor point on these superficial needles, which is actually something when I learned this way back when, is how important that is for superficial needling and moxibustion for pre-athletic events. And I've discussed that actually in chapter 4 of the SMA textbook, some of my findings with that. And it's points that I still use for any kind of pre-event type of stimulation. Because you're not actually going into the muscle, you're not causing any kind of soreness. You can go ahead and use a very superficial technique with some moxibustion. Again, that's in chapter 4 of the SMA textbook. And here's just another image to be able to show stimulating the extra point jaw, jing-jong. I'm sorry for hacking the language. I do my best with that. It is the extra point just next to Ren 24. It is stimulating the depressor labii inferioris, right, which is a really good actually point to be able to use for facial paralysis or facial nerve paralysis. So this is one of the points that we'll use. You can see how the lip is protruding with that. All right, for a motor point, so there is a great likelihood that the motor entry point can be found in the central aspect of the muscle, which is the location that provides the best advances for neuromechanical efficiency to affect the entire muscle. All right, so let's take a look at this hamstring. So what we're looking at here will be a posterior view. And Jeff, I don't think I have the ability to have a cursor here, do I? Are you there, mate? Okay.
Not. I'm sorry.
Do I have the ability to use a cursor? I forgot to ask you about that.
I'm sorry, you do not.
Okay, so I'll just describe it. So on the left of this image, thanks, Jeff. So on the left of this image where you see the Y coordinate, okay, so that's going to be around the UV36 region. So then you see the sciatic nerve that is just underneath that. So again, you're on the posterior aspect of the hamstrings here. So if you follow that sciatic nerve, that tube-looking thing that's right in the middle, follow that down where you see MEP. All right, so the MEP is going to be one of the primary motor entry points for the biceps femoris long head. This is a great point, and this is actually a very consistent point from specimen to specimen about where it's located. It's located just one soon lateral to UB37. So then now, you can see that the MEP, now there's going to be a smaller collateral branch that's going to the PLP. All right, so that's going to be a proximal collateral branch off of the sciatic nerve. So channels and collaterals, Jing Luo. So you've got your sciatic nerve and you have your collateral branches. So that smaller, thinner nerve that you see, that PLP, that'll be an intramuscular motor point. So that could also be something that we would needle. According to trigger point theory, this would be one of the areas where a trigger point could actually develop here as well. Now let's go back to the MEP. And as you're going distal, you'll see the branching of that collateral branch going all the way down to the DLP. And then it becomes thinner and thinner and thinner to the DLP. And then that would be another intramuscular motor entry point. Now, from my research, if you would go ahead and treat the motor entry point with an acupuncture needle, if there is tenderness at the PLP or the DLP, it decreases significantly once you end up getting the proper chi sensation at the motor entry point. Now, it's not to say that you want to go ahead and treat the DLP or the PLP, especially if there was a trigger point involvement there. And if you palpated that area and it's referring down the leg or to the lateral side of the knee or something of that nature, and that's what the patient's complaining about, by all means, that's going to be a very important assure point to go ahead and treat that's triggering that pain. In addition to treat the motor entry point, because that helps to signal the central nervous system about what's happening proprioceptively to that muscle. I hope that helps. Now, with our own dissections, our cadaver dissections and AcuSport education and our sports medicine acupuncture certification program, what we have found is that there's usually going to be one primary large diameter, very large diameter motor entry point for each muscle. Now, if there's going to be two or more, which does happen, the adjacent motor nerves are usually smaller than the primary one. Right? So there's usually going to be one that's going to be much larger than the other ones. Now, this larger diameter motor nerve is usually more reactive to surface electrode stimulation, now compared to many intramuscular motor points, because the intramuscular motor points are going to be smaller and thinner. Now, that's most likely just common sense due to the higher quantity of motor and sensory nerves located in the larger diameter motor nerve. And here's an example of that. So what we're looking at would be a lateral view of the anterior hip. And what you can see here is, after probably an hour and a half of dissection to clear this area out as much as possible, you've got your femoral triangle. So you see liver 10 there. So that means that just above that will be the ilioinguinal ligament. So there's a needle that is in the liver 10 region. Now, let's remember that liver 10 is located 3 sum below stomach 30. Stomach 30 is going to be on top of the pubic symphysis, 2 sum lateral from Ren 2. So we are below the edge of the pubic bone. Now, that muscle that you see that's attached close to liver 10, that is the adductor longus. So you can see where the call out there says primary adductor longus MP. Primary adductor longus MP. So that needle is going from medial to lateral. Now, if you look at the call out on the lower right, it says large diameter motor nerve branch. So there you can see a motor nerve branch, a collateral branch, coming off the obturator nerve. Right next to it is a smaller motor nerve branch that travels in the intramuscular tissue. Now, remember, on this particular specimen, we followed that smaller intramuscular tissue, that intramuscular branch, and it got so thin that we lost it. Didn't know exactly where it went. So 3 sum down from liver 10, needling from the medial side into the adductor longus, and you can see that we need to go into at least halfway into that muscle in order to affect the motor innervation. Again, if we just go ahead and tap on the needle and just touch the muscle itself, yes, we'll get a chi sensation. But will it be enough to change an elevated ilium? Will it be enough to take pain away from adductor longus tendinopathy? Maybe it will. My experience, it usually doesn't. We need a little bit stronger stimulation in addition to connecting these points with adjacent and distal points. Because the patient is just not about motor points. I mean, shoot, you guys, a motor point is just an Ashi point. That's all it is. It's just an Ashi point. It's a specific Ashi point, but our patients are much more than that, right? I mean, we went to school to understand traditional Chinese medicine, and we have to incorporate everything that we've learned to treat that patient for who they are. So this conversation is basically going to be a discussion on really great Ashi points to incorporate into your already existing practice. So speaking of that, let's go into this next one here. We've got, oops, there we go. All right, so these are some of the sports medicine acupuncture motor point protocols that have developed over the decades, you guys, over the decades. And in this very short discussion that we have right now, there's no way that I'm going to be able to discuss intricately every single one of these. So we're going to just kind of go over them, discuss them, give them a couple examples, and we'll move on to the next one. Some people will probably catch on. Some people may not quite understand it, but at least if it's going to be maybe a couple of light bulbs will go on, you might be able to think about a certain patient that you could be able to utilize some of these different techniques with. So let's keep moving on. Let's see what we got. So the Wakto Jiaji and myotoma motor point needle technique, this is probably one of my favorite go-to techniques for any kind of radicular pain, in addition to any injury that is occurring because of spondylosis, for example. If somebody has, let's say, you can see this x-ray that's on the left. You can see the space between L5 and the sacrum. It's very cloudy. The intervertebral foramen is very cloudy. Let's compare that to the space between L5 and L4. It's a greater space in there. The disc looks a bit better. There's a greater intervertebral foramen. And gosh, if we go even higher, between L3 and L4, very clear intervertebral foramen and a pretty large disc space. Now, bring our attention back down to L5S1. Now, that disc looks very narrowed. Possibly, if it is impinging on the nerve well enough, it could cause sciatica type of signs and symptoms. But what about the stages before that? What about the stages where it's not causing sciatica, but yet it's pressing on the nerve root with enough pressure that is then decreasing the amount of qi, the amount of trophic factor, going through that nerve into the innervated tissue, into that innervated tissue being the myotome. So what's a myotome? Myotome will be the group of muscles innervated by that certain spinal segment. And I actually have a chart for you here in just a second. Let's say that a patient comes in with a hamstring strain and they're maybe 40, 50 years of age. Well, normal degenerative changes of the spine, or spondylosis, could be occurring and decreasing the amount of qi to that hamstring. But it's not great enough pressure to cause sciatica. It's enough pressure to actually decrease the amount of qi going into the hamstring. So in this case, we would go ahead and treat the Wato-Jiaji points in addition to the myotoma motor points because it's all the same nerve. Let me explain. On the right, what we're looking at, it looks like roots basically. This is your dorsal primary rami. So the dorsal primary rami is branching off and it's going to the posterior aspect. Now that posterior aspect, that's where the Wato-Jiaji point is going to be. So if we stimulated that medial dorsal primary rami, where all those motor innervations are, with an electrically conductive needle at the Wato-Jiaji point, if you follow back down to the spinal nerve root, then the anterior rami, that would, in the lumbar region, that would be going then down the leg, part of the sciatic nerve. So therefore, it's basically the same nerve. You can stimulate the Wato-Jiaji point and the muscles that are innervated by that segment with acupuncture, and it communicates. This is something that we show in the SMAC program all the time. Somebody will usually have in a group of the live seminars, which I miss so much. Somebody will usually have one leg that feels a little bit different than the other, or the arm feels a little bit different than the other, and they have to be usually at like 40s or 50s. So we know that normal degenerative changes of the spine is occurring. But everybody has usually one side that feels a little bit different than the other. They might have spondylosis decreasing the amount of qi going down to that leg or that arm. So, for example, we'll bring that person up in the front of the class and we'll do a straight leg raise, and we'll see that the range of motion, let's say on one side, the affected side, let's say, is at, I'm going to say 45 degrees. Not causing sciatica. This is just one example, you guys. Let's say it's at 45 degrees. And then the opposite, let's say it's at 65 degrees. If we turn the person over and just treat the Wato-Jiaji points, just going in, stimulating the Wato-Jiaji points, and then taking the points out, not a full treatment at all, people. This is just a demonstration. Again, just inserting the needles at the Wato-Jiaji points, taking them out, flip the person right back over. The affected leg will then raise up significantly better. This happens time and time again. In fact, it's so predictable that I don't have a problem doing that in front of hundreds of people at a seminar. It is so predictable that way. So your Wato-Jiaji points are directly stimulating those myotoma motor points in addition to the myofascial tension that's causing that. And when you combine the Wato-Jiaji points then with myotoma motor points, it's just a fantastic combination with that. And I think we can actually talk about that now. Yes. So for you guys that have the sports medicine acupuncture textbook, it is described, this treatment method is described on page 106, but this image on the right is on page 692. So this is something that I'll use quite a bit for sciatica, or like I said before, it can be a hamstring strain or a knee problem or something, or some kind of myofascial treatment that seems like it's going to be caused by spondylosis in this 40-year-old, 50-year-old, 60-year-old person. Right? So treating the Wato-Jiaji points and then treating the myotoma motor points. There's a signal back and forth with this, and this is going to be really quite important. But this is only one treatment method. So you would combine this treatment method with, of course, your back shu points with the patient's constitution. How's their shen? How's their diet? How's their sleep? Everything else in order to be able to treat this person. Okay, where did I get this? This was an evolution from Chan Gun's work on tenderness at myotoma motor points, where in fact, he's a brilliant person. Chan Gun, if you're not familiar with him, he's got some really great articles that are out there. It's two N's, Chan Gun's, G-U-N-N, G-U-N-N. He's got some really great articles out there. He inspired me quite a bit to evolve his work more with the TCM basis, because he didn't include the Wato-Jiajis with the myotoma motor points at all, which I didn't really understand that, why that he didn't do that. Possibly just because he's not an advocate of traditional Chinese medicine whatsoever. So, however, he's quite the pioneer, and he has changed a lot of people's lives with his work. So Wato-Jiaji and myotoma motor points, this was one of my favorite treatment techniques that I use. Now let's go into the Wato arc. This is based on putting the electrical pad on the agonist and then putting the electrical pad on the antagonist way back when in the mid-1980s at San Diego State University. So the reason to do the electrical pads there is to change the relationship of the muscles within that neural reflex arc, or also the simple stretch reflex. So you can see this image at the top right, that patellar hammer reflex, the simple stretch reflex. Well, that communication, you guys, goes from the muscle spindles which surround the motor points in the quadriceps to the innervating spinal segment. And then the innervating spinal segment then goes to the antagonist. You know how fast? 20 to 40 microseconds. It goes that fast. The reason why is because there's no delay. There's no major synapses that slow things down. So if we connect motor points, Wato-Jiaji points, and then the antagonist motor points, there's a nice clean signaling system that happens with that. So that's how I came up with the Wato arc. In the very beginning, I used to write about, before I actually named it the Wato arc, in my writings, I would call it, well, go ahead and treat the agonist motor points, and then go ahead and treat the innervating spinal segment of not only the agonist, but also the antagonist. And of course, the words were changed a little bit. Gosh, but it was really a mouthful to be able to keep saying that kind of thing with this treatment method. So finally, just ended up coming up with paying homage to Wato, and there was born the Wato arc. So in this case, let's say somebody's coming in with patellar tendinopathy. You could treat the rectus femoris motor entry points, and then go ahead and treat the hamstrings motor entry points, and you would treat the Wato-Jiajis that are going to be level with the innervation of both tissues. And in this case, that would end up being L2, L3, L4. And then that would complete your Wato arc. Again, that's only one treatment method. You would be doing a lot more things in addition to this, adjacent needling, distal needling, treating the person's constitution. Let's give another example with this. Let's say that this woman on the right was jogging, she's coming in and she's complaining of pain in the low back, and her hand, let's say, is right there on the right. Forget about her hand on the left. Let's just say that her hand's on the right. This is a common body position for what I call Yao-Yan syndrome. So Yao-Yan syndrome is based on where extra point Yao-Yan is located. I think everybody's familiar with that. 3.5 swim lateral from the lower border of the spinous process of L4 is extra point Yao-Yan. And it sits right on top of the iliac crest, right on the edge of the iliocostalis and the thoracolumbar fascia. So that's the superficial layer of Yao-Yan. But if you go deeper, Then you've got your quadratus lumborum level. And there's ways to assess which one's going to be the most affected. But anyways, let's say that this woman's complaining of pain in that area. You've diagnosed it as Yao-Yan syndrome, being quadratus lumborum level. There you go. You've got your agonist. So your quadratus lumborum would be your agonist, your prime muscle. So we would treat the quadratus lumborum motor entry points. And then we would also treat T12, L1, and L2 because those are going to be the spinal segments that innervate the quadratus lumborum. But what's the antagonist? The common antagonist to the quadratus lumborum will be the opposing quadratus lumborum on the opposite side. In addition to, this is a good one, is the internal oblique on the opposite side. Gallbladder 26 is the primary motor entry point for the internal oblique. So if you could picture that, patient's laying prone. You have an acupuncture needle in the quadratus lumborum motor point. You have Wato Jiajis at T11, I'm sorry, T12, L1, L2. And then on the opposite side, you've reached over and you've inserted gallbladder 26 into the internal oblique. You now have a signaling system happening with all of those points. And you would take that treatment method and treat the person constitutionally and do other, like I said, adjacent and distal points to be able to make sure that all of the points are communicating. That's the art and skill of acupuncture, is to really step back after you put all the needles in and to make sure that as each one of these points have intent, do each one of these points have a direction, and are they signaling to one another? That takes a long time, the art and skill of acupuncture. And I'm no expert at it, but that's something that I strive to do all the time. Oops. There we go. All right. Motor points and channel mirror imaging. This is on page 111 in the SMA textbook. This one, put in your back pocket because this one helps a lot. And it's actually kind of fun to do. It's kind of fun to do with friends and family because you can change pain pretty darn quickly with this. Now, it's based on the mirror imaging technique, which is something that was written about in traditional Chinese medicine thousands of years ago. I had this discussion with the late, great Giovanni Macchiosa. Gosh, we lost an icon for it there. We lost a real leader there. What a giant. But I had this discussion with him about where did this actually come from. And he talked about how it's written in the classic thousands and thousands of years ago. And he actually he discusses it quite a bit in his books. Then Richard Tan took the idea of channel mirror imaging and put it in a really clear, linear way of understanding. And he really took it to a whole different level, right? So they're talking about losing giants, Richard Tan, obviously. So based on the channel mirror imaging, I've kind of changed it a little bit, and it works pretty darn well. So here's a case scenario. Let's say a swimmer comes in to see you. It can be anybody, you guys. I'm just talking right now. Comes in to see you, and they have shoulder pain, right? And you do the orthopedic examination painful arc test, where they raise the arm up, right? And they start to get pain around that large intestine 15 region. What you're looking for is supraspinatus tendinopathy. Well, the supraspinatus, as we know, deep to small intestine 12, it's associated with this small intestine Jingjian, small intestine sinew channel. So what I'd like for you to do whenever you get this case where somebody has a painful arc is to go to the opposite side adductor longus motor point. Now, we just saw that earlier in this presentation. It's located 3 cm below stomach 30. It's that cylindrical edge of the muscle, pretty easy to find, very prominent muscle, adductor longus. So one of the primary motor points is located 3 cm below stomach 30. What I'd like for you to do is to firmly press your fingers so the patient's standing up, they have a painful arc, their arms to the side. Firmly press your finger directly into the adductor longus. Now, just not a nice touch. You're going in there and pressing. Of course, ask permission first because you're fairly close to the genitalia. All right, so then press on that. Then, have the person raise their arm up and see if it is significantly better. Now, we're not talking about a torn muscle. We're talking about a supraspinatus tendinopathy where it's irritated. They have the painful arc for sure, but they're still able to move. Usually, what will happen is when you press on that adductor longus firmly, it will change that painful arc. All right? Now, how that's working is going to be you've got shoulder, abduction, supraspinatus, small intestine. On the opposite side, you've got hip, adduction, adductor longus, liver. You're the liver sinew channel. So you have liver, small intestine, midday, midnight. If you want to go farther with this, for those people that are measuring posture, you will commonly find an explanation with posture as well. They'll usually have an elevated ilium, and they'll also have a superior shift to the shoulder, which really starts to match why this midday, midnight correlation starts to work. It's fascinating. Love it. Absolutely love it. So that's something that I'd like for you to try. There's quite a few other examples in the sports medicine acupuncture textbook to use. So yes, motor points and channel mirror imaging. Oh, which by the way, so what that means with that assessment is that yes, you would be treating small intestine 12 on the supraspinatus side, and of course liver 10, the adductor longus motor point, on the opposite side as part of your treatment technique. Of course, we need more points, of course, to be able to treat. So that's one way of doing it. All right, empirical motor points. Now, these are going to be motor points. Well, first of all, let's describe what empirical is. As we know, as acupuncturists, we were taught certain points that act kind of like magic that you would use for a particular distal area. For example, stomach 38 is an empirical point for shoulder pain. We were taught that. Lung 7 is an empirical point for neck pain, right? Over the years, I have found that there are certain motor points, motor entry points, that have a profound effect on a distal site. There's quite a few of them. One of the most predictable ones will be the piriformis motor point, and how that can change the tissue tension and pain in the urinary bladder 10 region on the same side. In fact, it's so common that it will change that tissue, is that if I'm needling the piriformis motor point and it doesn't change the tissue at bladder 10, then I've missed the piriformis. That's how predictable it is. In fact, it is so predictable that during big seminars, I'll usually call somebody up that I can go ahead and needle, and then I'll call somebody else up out of the audience, and I'll have them place 2 fingers over bladder 10 on the same side of the piriformis that I'm going to needle, and just place it softly there. And then once I needle that piriformis motor entry point, 9 times out of 10, they'll feel a fasciculation. So there's this connection along this myofascial jingjin, like you can see this image here, where it could be a blocked area around the piriformis. Once you free that up, it signals up at bladder 10. It's kind of miraculous, actually. It's very, very predictable. So again, when you have a patient coming in, let's say with muscle tension headaches, they're having pain in that suboccipital region, remember the piriformis motor point on that same side. That will change the tension. So palpate the tension, needle the point, go back. It should be reduced, that tension, by at least 50%. If you have somebody else feeling it, they'll usually feel a small fasciculation. In fact, we just did this. We just finished recording the module 2 motor entry point protocols, recordings that LASA will have eventually. And we had a model go ahead and feel, and the model felt that fasciculation. So it's really very, very, very common. So this is a good empirical point to remember for this one. And I think we're on to the last one here. We've got some motor points of the myofascial sinew channels. This is something that is classic for, actually, this is probably really very close to what's discussed in the Ling Shu in chapter 13 on the treatment of Ashur points for the Jingjin. So what they talk about is to feel Ashur points all along a particular channel. Now, what my comrade, my colleague, my good friend, Brian Lau, and this is some of the artwork that he's been doing through a program called a Zygote, I believe. We've been putting together muscles that belong in the Jingjin according to our understandings of it, based mostly on myofascial connections and functional anatomy. What muscles are communicating with what muscles? What tissues are communicating with what tissues? So here, in this case, let's say, for example, on the large intestine Jingjin on the left, you can see this image on the left. Let's say that a patient's coming in with lateral epicondylitis. So two common points to use for lateral epicondylitis would be the EDRL and the ECRB. Extensor digitorum radialis longus and extensor carpi radialis brevis. That's not right. It should be extensor carpi radialis longus and extensor carpi radialis brevis. It should be EC there. I'll tell Brian. So you've got ECRL and ECRB. Those two muscles themselves are going to be important for lateral epicondylitis. Now, other points that you could use would be any kind of tension within the lateral intramuscular septum. Maybe there's Ashur points there. You could then follow up into the deltoids and see if there's any kind of Ashur points within the deltoids and then treat those as well. You can also look at the upper trapezius, middle trapezius, lower trapezius, all of that being part of that large intestine Jingjin. Because those myofascial tissues, they all communicate with one another, they're all linked together. So we could treat those motor points of extensor carpi radialis longus and extensor carpi radialis brevis, but then also match with other Ashur points in the region. So let's go to the heart here, because I think we're going to be going into a couple of videos here in just a tick. We're going to go into the extensor carpi radialis longus and extensor carpi radialis brevis. That'll be presentation that's straight out of module 4 that LASA OMS has on the location and the needle technique for it. Then we'll also discuss the pectoralis major. So the pectoralis major is such an important muscle to really be comfortable with treating because of its influence on a forward shoulder and for shoulder pain. So this is something that's going to be important. And in fact, one of the motor points is an empirical point for stomach pain, especially when there's cold in the stomach. And I have a funny story for you once we start getting there. So let's go ahead and move on. Let's see here. All right, so we've got the extensor carpi radialis longus. So like I said, this is going to be, what I did is I grabbed some of the presentations from the module 4 and just threw it right in here so you guys can be able to see if you were wanting to investigate any of these recordings, what you would be getting. So we're going to be discussing the extensor carpi radialis longus and brevis, where the motor point actually is, and how to actually go ahead and treat that. Let's see, Jeff, is the next one, is that actually the video? Let's see, yeah, I think it's just it's the video. So Jeff, you want to go ahead and pop onto that?
Sure.
Extensor carpi radialis longus and brevis motor entry points are located on the large intestine channel. So let's locate large intestine 11, which is going to be just up from the lateral epicondyle, and it's going to be at the very end of the transverse cubital crease, large intestine 11. So from large intestine 11 to large intestine 5, as we discussed previously, this is going to be a measurement of 12 sun for this particular patient. So if we divided this in half, that's going to be your 6 sun. Then we divide that in half, there's your 3 sun. Large intestine 10 is 2 sun distal from LI 11, and a line joining 11 and 5. So we've got the brachioradialis. There's the brachioradialis, so go ahead and press up against me there. So there's the brachioradialis, and relax. So the division between the brachioradialis and the extensor carpi radialis longus, let's go ahead and find large intestine 10. That's going to be the motor entry point from the radial nerve into the extensor carpi radialis longus. So then now, separating that tissue, here's the brachioradialis. All right, so then now I can feel the band of the extensor carpi radialis longus, but let's just make sure. So let's have the patient extend the carpes to the radial side, and there it pops right up underneath my finger, and relax. Okay, so then now I'm going to check the angle of which way I want to needle. Do I want to go more toward the radial side on this one, or do I want to go more toward the ulnar side on this one? And we just see which one's going to be the most tender. This particular angle seems like it's the worst one, at least for the density. And how does that feel to you? We have angle A and we have angle B. So we're going to actually needle angle A, and it would be in this particular direction for the extensor carpi radialis longus. So then now let's find the extensor carpi radialis brevis. The extensor carpi radialis brevis is usually indicated as the primary muscle for lateral epicondylitis, so we want to make sure that we identify where that motor entry point is. Let's find large intestine 8. Large intestine 8 will be another 2 soon down from large intestine 10. So we had 11. Between 11 and 10 is 2 soon. Then we have 10, 9, and 8. All right, so then now large intestine 8, now we're going to go just to the ulnar side and find extensor carpi radialis brevis. It's going to be a smaller, thinner muscle that lies right next to it on the ulnar side of extensor carpi radialis longus. So I'm going to palpate a large intestine 8 and go just slightly to the ulnar side. And I'm going to have the patient extend to the carpes to the radial side, and I can feel the muscles start to pop up and relax. Okay, so then now do that one again. There it goes, pops right up underneath my finger and relax. So therefore, same thing. Is it perpendicular that's more tender? Is it more toward the radial side? More toward the ulnar side? That's more tender. All right, so then toward the radial side seemed like it had more density to me. The patient said all of them were tender. So we've got extensor carpi radialis brevis, which is just to the ulnar side of large intestine 8. And we have extensor carpi radialis longus, which is going to be just deep to large intestine 10. Let's go ahead and check out the needle technique. So we've identified where large intestine 10 is. Let's just make sure that we've got that extensor carpi radialis longus popping up. So extend, if you would please, and there it is right there. Really nice cylindrical muscle. Okay, and relax. So I'm going to press toward the radius. I'm going to press toward the ulna into that muscle and see which one's the most tender. All right, so I'm at large intestine 10. I'm going to insert that just toward the ulnar side there. Okay, good. So then now let's get into extensor brevis, which is going to be right by large intestine 8, just to the ulnar side. This one was very tender on her, especially going more toward the ulnar side. These points are going to be quite indicated for lateral epicondylitis. So then now slowly extend the carpals to the radial side if you would. All right, we can see them moving quite a bit and relax. Let's see, I want to get this one angled a little bit better into that. Got a nice fasciculation there. And there we go. Now you can really see and relax. As we go, we extend the carpes to the radial side, so we can see that we're in those muscles. And again, here we go. And relax.
Okay, so for this one, you guys, thanks, Chad. For this one, let's remember those are just going to be 2 points. That's going to help with that lateral epicondyle, but being on the large intestine channel, we'd also want to do some distal points. For example, we could do large intestine 5, large intestine 3, large intestine 1. Now, also moving above that, we could look for Ashi points within that lateral intermuscular septum. We could go into the deltoid to look for Ashi points. If we want to connect the Wato-Jiaji points, which I highly suggest that you do, that would be a Wato-Jiaji point at C6, C7, and T1, because that will be the spinal segment that's innervating those muscles. because then you get that communication coming from the spine and all the way down that channel. If we're going to do the Watto arc there, then we could do what's the opposite of extensor carpi radialis? Could be flexor carpi ulnaris. We could use something like flexor carpi ulnaris and see if that's really quite tender. So using agonists and antagonists. Lots of different ways of thinking about doing this. All right, so let's get into the next one here. Let's talk about the pectoralis major. There are many different motor points for the pectoralis major, but again, where are the largest diameter motor entry points? And this is what I'm going to be showing you right now. All right, so we have the clavicular fibers is going to be at stomach 14. So you guys, you may want to make a little note on this one. This one is something you want to needle with moxa when you have cold in the stomach. And I found this out because I remember that the clavicular fibers were associated with the stomach in applied kinesiology and also John Thee's work. Now, this is way back when, you guys. This is going to be in the 80s. And so after eating an entire pint of vanilla Swiss almond Haagen-Dazs, loved every single bite of it, I wasn't feeling very good afterward. And I remembered that effect. And I treated stomach 14 with moxa, and within minutes that pain was gone. And so then I took that information clinically, and anytime that I had a patient like that, I did the same thing, and it works pretty darn well. Especially, it works so well, it's like taking a pingwei san. You know, pingwei san, I think it's a magnolia and ginger combination, which is really quite good for cold in the stomach. So remember stomach 14, that's a good one for stomach pain, especially when it's actually more of a cold stagnation. All right, so then now another motor point is going to be stomach 15. So one soon lower, but you have to go just slightly lateral. So you're going to insert at stomach 15 and angle it slightly lateral. The lateral pectoral nerve is going to be innervating stomach 14 and stomach 15. Now another motor point, this is a really juicy motor point, you usually get quite a fasciculation with this one. It's located halfway between stomach 16 and the anterior axillary fold. And there's a lot of people that get a lot of congestion in that region right there by the anterior axillary fold. This is a motor entry point coming from the medial pectoral nerve, and it's fascinating about the trajectory of the medial pectoral nerve. It actually comes from underneath, follows the rib cage, goes up through the pectoralis minor to insert into this motor entry point. So think about if there's any tension within the pectoralis minor, could that be decreasing the amount of chi of this nerve going to the pectoralis major? I believe so. I definitely believe so. Let's go into the next slide so you can see this a little bit more, and then I've got a video to show you. All right, so A is going to be your clavicular portion, which is going to be innervated by the lateral pectoral nerve, which is a branch off the lateral cord of the brachial plexus, right at stomach 14. Then just one zoom below, B, that lateral pectoral nerve has a collateral branch, and it goes just lateral to stomach 15. Then you've got C, which you've got the medial pectoral nerve that's coming underneath from the medial branch of the brachial plexus. It goes through the pectoralis minor, which is D. So D is going to be the pectoralis minor, to insert into those sternal fibers, sternocostal fibers of the pectoralis major. So 3 primary motor points. Great points to use for a forward shoulder, but also remember, when somebody has medial epicondylitis, which is affecting partially the heart channel, the pectoralis major is also heart. So we could use pectoralis major to help with medial elbow pain. We could use pectoralis major to be able to help with, let's say, any kind of pain in the wrist on the heart channel. So these are good points to be able to get to know. And let's go one more slide. This is going to be from one of our cadaver dissections that you can see. On A is going to be the pectoralis minor. Now B is going to end up being the innervation going right into the sternal fibers there. That's located halfway between stomach 16 and the anterior axillary fold. So that pectoral nerve, the medial branch going through the pectoralis minor up into the pectoralis major. So the tissue above is the pectoralis major. The tissue below, A, is the pectoralis minor. And then over here on C, you see that lateral pectoral nerve. So that lateral pectoral nerve is going to be going into stomach 14 and 15. So let's watch this video because you'll see different parts of the dissection with this, and I think it could be really helpful. Thanks, Jeff, if you can roll that.
We're looking at the pectoralis major motor entry points for the clavicular fibers and also the sternal fibers. The clavicular fiber is located right underneath the clavicle, and the sternal fibers that reach from the sternum and also the lower ribs coming up, blending together to make the pectoralis major. So to have the pectoralis clavicular fibers pop up, we're going to go ahead and raise that arm up. We're going to resist horizontal adduction. We can see the clavicular fibers pop right up here. Now, we're going to have the patient go ahead and take their hand and go toward the opposite hip, and I'll resist that, and there you've got the sternal fibers popping right up. And relax. The motor entry points are located at stomach 14, just lateral to stomach 15, on a line also that's halfway between stomach 16, which is located in the third intercostal space, and the anterior axillary fold. So if we look at the sternum, this will be your Wren channel. We know that lung 2 is going to be here at the coracoid process. If we divide that in half, that's going to be 3 sun, so we just come right over 1 more sun. We know that stomach 13 is directly underneath the clavicle. From here, let's go down to stomach 14, which is in the first intercostal space. Stomach 15 is in the second intercostal space, and stomach 16 is going to be in the third intercostal space. The clavicular portion, the motor entry point located at stomach 14, will take the needle and direct it from medial to lateral, angling it directly into those clavicular fibers. For the upper sternal fibers of the pectoralis major, the motor entry point is located at stomach 15 or slightly lateral. So from stomach 15, we'll insert the needle and direct it from medial to lateral, going right into the motor point innervation. For the lower pectoral sternal, we'll divide stomach 16 and the anterior axillary fold in half. We'll feel for the fascicles here in the pectoralis sternal fibers. We'll direct the needle going in from lateral to medial right into those fibers, but before we actually needle, we want to make sure we assess where the rib cage is. So we want to make sure we do not pass the plane of the rib cage. We assess where that point is, and in depth on him, it's about 3/4 of an inch to 1 inch deep. So from the surface of the skin, we'll go directly into that tissue, 3/4 of an inch to 1 inch deep on this particular patient. We found stomach 14 for the clavicular fibers, so let's go ahead and needle from stomach 14, from medial to lateral. Stomach 15. From medial to lateral. We saw a little fasciculation here. You saw that in the sternal fibers. And then another motor point, top of the anterior axillary fold. Stomach 16, divide that in half. Feel for the tight band, the fascicle. Then needle this one from lateral to medial right into that fascicle, but you've assessed the depth, which is about 3/4 of a sun to 1. Use a little joining valleys needle technique here. And propagate chi. There we go.
Okay, there was actually a cadaver video on that one. I'm not exactly sure. I must have got the wrong file, but that's okay. We're kind of running out of time. Let's move on to the next one, the sternocleidomastoid. All right, so we just have a couple of more here. So let's go run real quick into the sternocleidomastoid so you can be able to see I believe this one has a cadaver video as well, so you can check this one out. So Jeff, let's go ahead and go ahead and look at this one.
Here we're looking at the right sternocleidomastoid. If we turn the patient's head, we can see the sternal fibers of the sternocleidomastoid. The clavicular fibers will be deep, a flatter tendon here. To locate the motor point, we locate the Adam's apple or the laryngeal prominence. From here, we go to stomach 9. From stomach 9, we can find large intestine 18. Large intestine 18 is going to be in the belly of the sternal fibers, but there's also a branch of the nerve that goes into the clavicular fibers. So we can access the sternal fibers and the clavicular fibers through this motor entry point. So from stomach 9, place a thumb. Here's 18. 16 is on the posterior border of the sternocleidomastoid. So now take the muscle, just pinch it and feel for the most density, and it'll be the most tender spot for the patient. If this particular location is not tender, then go ahead and move up just a couple of millimeters and press there. Now this feels a little bit more dense to me. This is probably going to end up being the motor entry point. The needle angle will be from stomach 9 directly toward L.I. through the sternocleidomastoid. We want to make sure not to needle perpendicular here because of the carotid and the internal jugular. So we thread right across this region. Stomach 9, L.I. Pinch up the muscle, feel for the density, the depth of it. Bring the muscle back so the anatomy remains the same. Insert at stomach 9. Thread the needle across the sternocleidomastoid and into the motor entry point location. We're looking at the lateral view of the sternocleidomastoid. Here's the side of the neck. Here's the sternocleidomastoid. Here you can see the clavicle, part of the pectoralis major fibers. Here's the sternal head of the sternocleidomastoid. Here's the clavicular head of the SCM here. We know that the motor entry point from the accessory nerve to the sternocleidomastoid is level with the laryngeal prominence, which is level with stomach 9. From stomach 9 we have large intestine 18, which is in the muscle belly of the SCM and where the motor point is located. On some individuals the motor entry point is located maybe a half a soon higher. Let's go ahead and take a look here. So if we retract back from stomach 9, we'll just pull this right back. We can see a large diameter nerve, this accessory nerve here, going right into the SCM sternal fibers, but also it's going into the clavicular fibers at this level. Now what you're going to be seeing here will be the vascularity to the SCM. Now there might be some nerve tissue in there as well for motor entry points. This is the largest one exactly for here. This is the largest one that's going into large intestine 18 region. So therefore, in the supine position, if we needle from stomach 9 towards large intestine 18, we can affect that motor entry point at large intestine 18, where the needle going right into that motor entry point of the accessory nerve here. There we go. There it revealed itself there. You can see a really nice view of it there. Small little fat pad, usually that you'll see at motor entry points. There's the nerve tissue, that white tissue, and here's more of a reddish tissue, so that's going to be more of blood vessels. Now, if the patient's going to be prone, it's easier to needle this point from SI16 toward LI18 when the patient's prone. When the patient is supine, going from stomach 9 to L.I.18. This is the motor entry point for the SCM, sternal fibers, and clavicular fibers from the accessory nerve.
All right, I hope that was helpful. You guys, thank you so much. I'm not going to take much more of your time. However, I want to show you one other point that is under investigation. I don't know if it's the motor point, but it's also an extra point that I found called jianxi. It's great for knee pain, especially when there's knee pain in the anterior aspect of the knee. If we can spend just another 5 minutes discussing this one, and that would be wonderful. Let's jump right into it. This is a wonderful point. I love this point. It is looking at the articularis genu. Now, the articularis genu is an extremely thin muscle that lays right on the distal aspect of the femur. Right? Its whole job, what it lives to do, is to pull on the suprapatellar synovial bursa to be able to pull it upward so it doesn't get entrapped with knee extension. Some authors talk about the articularis genu should actually be part of the quadriceps because it has an innervation and it is active during knee extension. Anyways, the articularis genu, again, is a very paper-thin muscle. What an incredible and difficult dissection it is to be able to find this motor entry point. Myself and Brian have failed at this probably 4 times with it. Many times this articularis genu is embedded within the fibers of the intermedius. Challenging. However, we still want to go ahead and find it. There's going to be some research out here I want to discuss that it's a possibility that maybe the motor entry point is located about 3 sun above the superior border of the patella. Let me explain. So the suprapatellar synovial pouch, the bursa, it's a large continuation of the synovial membrane of the knee joint proximal to the trochlear groove. Now, the upper border of this synovial pouch is located approximately 6 centimeters proximal to the superior border of the patella. So remember that extra point Hayding is located there, you guys, at the superior border of the patella. So we're talking about the upper border of this synovial pouch is located about 6 centimeters proximal to extra point Hayding. So let's remember that. It lies deep to the quadricep tendon. So remember, this articularis genu hangs on to that, and it pulls it up out of the way so it doesn't get pinched by the patella in the trochlear groove. That's its whole reasoning, right? So that upper border of the synovial pouch is located about 6 centimeters proximal to the superior border of the patella. Now, I found this article. You can see Grob K 2017. It'll be in the references. So the references are at the very end of this, you guys. So anything that you want to go ahead and check out, please feel free to do. Lots of great information out there. One of these terminal branches talking about the femoral nerve is what these researchers found. Course distally above the deep layer of the vastus intermedius, because we know the articularis genu is underneath the vastus intermedius on the femur. And it branched to the articularis articularis genu, finally inserting into the upper part of the synovial pouch of the knee joint. So what did we just learn? We just learned that the upper part of that synovial pouch of the knee joint is about 6 centimeters, right? Okay, so if you look at 6 centimeters on a ruler, that's about 3 sun. There's an extra point called jianxi, and it happens to be translated as strengthened knee. It's located 3 sun directly above the center point of the superior border of the patella. The supine patient has their knee flexed at 45 to 60 degrees, and the practitioner uses a 1.5 to a 3-inch needle, depends on how big the person is, angled with a slight inferior and oblique direction to the bone. We're going to see a video here real quick. I believe this is going to be probably the motor entry point for the articularis genu, but I can't confirm it yet until we actually find it ourselves. When you do stimulate this point, and you have the patient in this particular position, the sensation will usually travel into the anterior knee. All right. Jeffrey, let's see. Oh, do I have one? Yeah, Jeffrey, can you go ahead and throw that on there, please?
Extra point Hoding, 3 soon above, extra point Jiansher, perpendicular, angle slightly inferior. Insert the needle through the rectus femoris to the bone. Once we hit the bone, we know we're affecting the articularis genu. Come up slightly and propagate.
Okay, that's it. So throw that into your tool bags, please. That is a really great point. I've had some good success with that one. All right, so just remember, after we do our acupuncture to motor points and such, make sure you're doing your any kind of myofascial release techniques. Maybe you're doing Tuina, maybe you're doing something else. Also, exercise prescription is great to use because it is priming the person. You've done all these different, you've done stimulation of motor points, channel points. They are so ready for more proprioceptive re-education for exercises, and this is something that we do in the SPAC program. You guys, thank you so much for staying late on the East Coast. I really appreciate that. Is there any questions that I can be able to help out with at all? Jeff, do you want to read any questions at all, or how do you want to work this?
Hey, Matt. Yep, we have a couple questions here. So if you have a few minutes, let's get into it.
Sure.
All right. First question. Can you explain the exact difference between a motor point and a trigger point? And then are all motor points trigger points?
Yes, I can. But I want to refer you to a really wonderful discussion that Brian Lau and Josh Lerner and myself, sorry, we have some flies here, that's why I was waving here, that Josh Lerner had a really great discussion for about an hour or so. And that was on the American Acupuncture Council webinar just last month. Maybe it was 2 months ago. There's a lot of information on that. So the difference between a motor point and a trigger point, and this is going to be putting it in a nutshell. A motor point is going to be an anatomical entity. A trigger point is going to be a result of a manifestation of dysfunction. Now, a trigger point can live in the muscle, and where it can live, it can be at the motor entry point. It can also be at intramuscular motor points. A trigger point could also be located in musculotendinous junctions, periosteum, ligaments, joint capsules. Areas of stress is where trigger points can go ahead and live. So there is a difference between a motor point and a trigger point. They can share locations, but they also many times do not share locations. I refer you to that conversation that we had.
All right. Let's see. Next question. What frequency are you stimulating the Huato arc and for how much time?
Gosh, you guys, you know what? I don't know. I don't know. I plug in my Ito and I stimulate it. When I am using electric stimulation, which is not very frequent, I'll use it on excess conditions. Like, for example, let's say a quadratus lumborum motor point and yaoyan, let's say, something of that nature. I'll plug in and play. I'm not the expert. I would suggest if you want to learn about electric stem, there are two great teachers out there, Jeremy Steiner and Michael Corradino. For me, I rely more on needle technique and trying to be able to get needles to be able to communicate with one another and do a lot of myofascial work and such. So I'm not a big E-stem guy. Nothing about it. It's just not my cup of tea. Go ask those questions to the guys that can answer that better.
All right. And we'll actually be hosting both of those gentlemen for webinars in the near future. So save your questions for them.
Awesome.
Next question. Do you have any tips when working with muscle spasms, say with lower back pain?
Is it acute or chronic?
That we don't have. Andre, if you're still here, feel free to put it in the questions tab. if it's acute or chronic. And while we wait for that answer, what if the pain is just to the medial side of the patella? Oh, actually, sorry. Let's go back to the last question. Sorry, he actually answered. It's chronic.
It's chronic, so it's a chronic muscle spasm. Okay. In a case like that, I want to find out what is causing the chronic muscle spasm. Is it a postural disparity that is making the muscle in a locked long or a locked short position? For example, if there's a elevated ilium and the muscle spasm is on the same side of the elevated ilium, causing a quadratus lumborum to be spasmed, then we need to decrease the elevated ilium if we're able to. If it's a congenital leg length difference, then it becomes more difficult, but there's workarounds with that. So we have to look at what's causing the chronic tension within that muscle. So not just a postural aspect of it too, but diet is a big part of it. What's happening with their blood? What's the tongue look like? Is there a lot of heat? Is there a lot of dryness? Is there a lot of blood deficiency? Are they going to be needing essential fatty acids to be help lubricate? So there's a lot of things to discuss here. In fact, if you wanted to jump on right now, we can chat a little bit about that if you want. I'm trying to be able to get more information from this because there's so many things to chat about. We can go to the next question until he's there.
Actually, he is not able to join on screen, unfortunately, in this particular platform. I apologize.
I wish I could answer more. There's just so many variables to be able to discuss with these chronic type of things. But there's lots to talk about for sure with it.
All right. Next question. So this is the question I was trying to ask. What if the pain is just to the medial side of the patella?
Okay. Well, is the patella tilted to the medial side or is it tilted to the lateral side? Do they have a valgus knee when they go into an overhead squat? There's a lot of things to look at to see what's causing the pain on the medial side. Many times, the vastus medialis, where it attaches on the medial aspect of the patella, can have an insertional tendinopathy. Now, that vastus medialis will be the fastest muscle to weaken when there's a disuse problem with the knee. Meaning they're not working, they're not walking very well, they're not using the knee very well. So you can get a tendinopathy there. But again, we need to look at what's causing the problem. Like, let's say, for example, with this patient, you watch them walk upstairs and you see that knee always going inward, always goes inward. That's going to be a real excessive pull on that medial side. So that would explain why there would be pain on that medial part of that patellar tendon, the patella. So I can't, there's a lot more to know. I'm just kind of trying to throw out a number of different things to look for in this one.
All righty. Next question. Do you always try to get a vesiculation when needling a motor point?
No. It's not necessary. It is absolutely not necessary.
Oh, and actually, we actually just got some clarification on the question about the patella.
Oh, cool.
The knee does go in, and it was after a zip line landing.
Okay, so it's going to be acute, and the knee does go in. So my guess, and again, this is trying to diagnose in this kind of platform is going to be really, really challenging. So let's just take it with a grain of salt here, is that if you palpate along the insertion of the vastus medialis on the medial aspect of that patella, it could be a tendinopathy. Now, depending on where it is actually on that patella as well, there's the patellar plica. Now, the patellar plica can get inflamed with acute injury too, which is a pinching of the patella underneath, pinching of the tissue of the plica underneath the patella. That's its own diagnosis. It's hard to diagnose it without actually seeing the patient there. What you could try is vastus medialis oblique motor entry points, popliteus motor point, making sure that the hip is really nice and strong, glute medius and minimus motor points. If the knee moves in, the glute medius and minimus are going to be weakened. So the gallbladder is going to need, the gallbladder channel will need to be strengthened. How's the person's spleen chi? Because that could be part of the equation here if that pain is going to be on the spleen channel. Again, I'm just throwing some ideas out based on the limited information that I have.
All right, let's do one more question. Do the knee motor entry points work for osteoarthritis in your experience?
Yeah, for sure. Absolutely. So in addition to kneeling motor points of vastus medialis, vastus lateralis, articularis genu, rectus femoris, popliteus, upper gastrocnemius fibers, you want to treat lateral and medial. You also want to treat the eyes of the knee. Make sure the eyes of the knee are going to be needled, gosh, a good inch and a quarter in at the eyes of the knee. That's where I'll E-stem this quite a bit. If the knee is feeling cold, then I'll do more moxa in that case. So depending on the treatment, some treatments will be E-stem. The next treatment may actually end up being moxa in that case. Like I said, if it's going to be cold stagnation. Osteoarthritis is very manageable. Palliative care, you guys. This is palliative care, right? We're not going to be curing this. We're going to be making the function better. Right? So just by treating the knee with those points that I just described, we'll put a Band-Aid on it and the person feels pretty good. However, we've got to remember that the knee is the halfway point between the foot and also the hip. So we got to look at the hip. How's the hip doing? How's the foot doing? And then also, how's the person's constitution? Are they so depleted in kidney chi that they're unable to actually hold the stability of the treatment? Is the kidney chi and yang so deficient that they're not walking so well? So this is something to be able to look at, not just from the knee pain, but who is this patient that we're treating? I hope that helps.
I think it does. And honestly, Matt, we cannot thank you enough. I've just been looking in the chats and there's like 100 comments of what a great class this was and how much everybody's learned. So I just want to let everybody know that Matt has both Module 3 and Module 4 and soon to be Module 1 of the Sports Medicine Acupuncture Certification Program courses available for sale at LASA OMS. Please check your email about 5 minutes after this webinar. You will have a promo code to use for those. Also, we have 15% off our top sports therapy products. So check out that link as well, which is in your email. One last plug for Lillian Bridges. I'm going to put that back into the chat again if anybody missed. But a dear friend of Matt in the industry is going through a really rough time and needs some help. So please take a look at that link. Also, I put it in the chat a little while ago. CSOMA is doing a webinar in about 30 minutes. If anybody has the appetite for a second one, it's about advocacy updates and legislative updates in both California and nationally. So please check that out. I will put the link back in the chat to that as well. Matt, do you have anything else you want to say to everybody before we go?
Thank you so much for hanging in there, you guys. I really, really appreciate that. And thanks for listening. I hope there was some useful information for you. And if you have any questions whatsoever, we're really good about answering questions. Our Module 2 actually starts this weekend. So thanks, you guys. Really appreciate it. And Jeff, it's always nice hanging out with you, buddy.
I agree. Well, let's do it more often.
All right. Thank you, LASA OMS. Take care, everybody.
Thank you. Have a good night, everybody. We'll see you next time.
Okay. Bye-bye.
Bye-bye.